you, all three of you, for being here with us. Today we're going to talk a little bit about the experience of our female veterans, how you think that is potentially different from some of our other veteran population, and also how this immersive technology could be potentially beneficial for them in different ways. So I'll be asking some different questions throughout this panel of our three panelists. Today we have with us, we have Dr. Lauren Siff, who is the Chief of Gynecologic Surgery at the Central Virginia VA Healthcare System. And definitely feel free to add to these if you need to. We also have Dr. Megan Rumsey, who's an innovation specialist and of course extended reality subject matter expert within the VA, who's now working at the Little Rock VA Medical Center. And we also have Leela Jackson with us, the Director of the Assault and Harassment Prevention Office. So thank you, all three of you, for being here. So I'd like to start this out with you, Dr. Siff. So of course, all veterans represent a very unique patient population. We know that within the VA wholeheartedly. And then female veterans within themselves represent an also unique population within that veteran population. So if you could share your thoughts on the importance of tailoring our care for our female veterans in general.
Yes. So as a urogynecologist, I take care of female veterans with pelvic floor symptoms, and those affect their bowel, bladder, and sexual function. And sadly, 50% of the women that I take care of have experienced military sexual trauma. And even just looking at the Richmond VA alone, over a 3-year period, there were 1,500 women seen with both a history of military sexual trauma and pelvic floor symptoms. And so you can imagine that these women, they report feeling silenced, dismissed, or made to feel at fault for some of the symptoms that they're experiencing, really as a result often of the trauma that they've undergone. So it's really important to tailor that care to create a sense of trust, openness, and be able to open the door for something for women who reasonably have a mistrust in the system. I also think that in addition to the sexual trauma, these women have experienced unique things related to something as simple as toileting, so in active duty. And so you will, as well as stress on the pelvic floor, within my specialty at the very least. And so they've had surgeries or procedures. Many of the times they don't feel that they were in shared decision making or even aware of what happened during those procedures. And so I would say it's extremely important to now include their voices in the care that we are going to provide. And what I'm focused on, and we'll get to a little bit later, I think, is utilizing VR during in-office pelvic procedures.
Thank you for that, Dr. Siff. And as a follow-up to that, Dr. Rumsey, in your work with immersive technology already, considering how special this patient population is and some of the challenges they've faced, how important is it to kind of tailor the actual immersive technology itself, whether the hardware, the software, the content, specifically to female veterans? And what have you kind of learned in that space?
So I just wanted to acknowledge Dr. Siff's work, and I think it's really extraordinary. I come at the immersive experience from looking at chronic pain and working not only within the inpatient population, but also doing work in the outpatient. Early on in this experience, we would use it with our inpatient, and they would say, I want to take this home. Where can I get this? How can I use this on an ongoing basis? Because I like it, I find benefit. So with the chronic pain population, what we found with our female veterans who we only had a few in the inpatient, but they would say, my pain is oftentimes disregarded. I'm challenged about when I say I have 10 out of 10 pain, I'm kind of like, put on the shoulder, pat it on the shoulder, it's probably not that bad, really discounted. And I think that time after time, that will kind of build up with you. So we did a feasibility study early on in COVID, and it is something that was pretty profound in terms of the results on chronic pain. And I am getting to your question. But to that point, when we were looking at the results, both quantitative and qualitative, the quantitative was easy to replicate between our population, and we had 3 females in this group of 10. Again, it was small, and it was during COVID, so we were proud to get it up and off the ground. But we were hearing different things from our female veterans about how they were thinking about this technology. And so then had an opportunity to focus on veterans, female veterans only, and we thought we would be looking at chronic pain until we looked at our catchment, and we found that the highest occurring chronic pain, low back pain, was not as high as PTSD. And so we got curious about, well, where is that PTSD occurring, and is, MST part of that? So to the point about the patient population and the technology, so the headsets, are the same, and female veterans use them the same as male veterans. They fit on the head, and that's all fine and good. But what we found when we started to explore the use of the immersive technology in the outpatient space with this PTSD cohort, was we started to get feedback like, I don't like the male voices. That makes me feel very uncomfortable. We also had an opportunity to hear feedback. There's a very common experience in VR headsets. It's called dolphin healing, and it's a lovely experience where you're looking at dolphins, and it runs the gamut from 6 minutes to 15 minutes. But it's a 360 immersive experience, and if you turn around, the filmmakers are behind you, and they're in neoprene suits, and it's quite threatening, actually. And our female veterans were saying, that feels very uncomfortable to me and makes me not want to be in the headset. So there are things about our female population that we need to consider. Once we got that feedback, we immediately updated our consent so that the next group, we want to be very actionable to support our veterans, female veterans have access to this information, and make sure that we are creating the best environment for them to have a quality experience.
No, absolutely. And I think that's amazing feedback to provide those that are developing content as well, so that we are really taking into consideration those special experiences of our patients, something that's very unique to them, to make sure that we aren't unintentionally triggering our patients when attempting to help them, and so taking that into consideration. So thank you for that story. Leila, I wanted to ask you, so the technology, what do you think is the potential of this technology in specifically impacting female veterans, as well as allowing others to better understand the experience of our female veterans?
Thank you, and thank you so much for allowing me to be on this panel. I am a female veteran and served 20 years in the United States Marine Corps, so this is near and dear to my heart, and I love working for the VA in this capacity. So my role, I need to start out with my role at VA. I'm not a clinician. I lead an office called the Assault and Harassment Prevention Office, where we're thinking about this all day. And I sleep about it, I dream about it. I'm thinking about, how do I keep our facilities safe? How do I keep VA safe? How do I keep VA the place that employees want to work and patients want to keep coming back to? And Dr. Shea mentioned walking in their shoes, and she talked about the provider, walking in a provider's shoes, but as she said that, I thought about this panel and what we're discussing today, and walking in a veteran's shoes. We want our women veterans to come to VA, and some women veterans don't come to VA because they have had bad experiences while they're on active duty. They might have some misconceptions about what we do in VA healthcare and what it might be like, or they may have talked with other women veterans who've said that when they walk in their facility, they might walk the gauntlet. And that means that they may feel like people are gawking at them as they walk to their appointment. These are anecdotal, real stories that we've heard from women veterans, and we've heard from our Women's Health, we've heard it from our Center of Women Veterans, we've heard it from veterans themselves. So we know that's true. And let me just say this, harassment in VA is not just a VA thing. This is a national discussion. The Joint Commission has included sexual harassment in their definition of workplace violence. The CDC says that 1 in 4 women experience harassment in their lifetime or some type of sexual violence in their lifetime, and 1 in 10 men. And those numbers change. I mean, those are the last stats that I looked at. So it's not just a VA issue, but what I'm proud of is that VA is taking this issue very seriously. Our undersecretary, our secretary, this is an important, that's why we have this office that I lead. I'm fortunate to lead. And so I have to say that Dr. Ann Bailey, who's here, was talking to me about, how can we use VR in training some of the work that you're doing, like maybe bystander intervention training. And at VA employees are used to using, that we call it talent management training. We use next slide, right? And so I thought maybe this is something. And we're really fortunate that we have the opportunity to do innovative things in my office. We are, very fortunate. So I thought maybe we could help people have a more experiential, opportunity if they've never experienced harassment before, or they're not a veteran. Or I can say that I have walked into the DC VA, I've never experienced harassment. So if I'm now using the VR, and now I'm the veteran walking in the medical center, and I'm experiencing harassment, what type of techniques can, because you're the learner, you're learning it as an employee, but you're seeing it from the veteran's eyes, what kind of techniques can I use to prevent that harassment? How can I make their experience better? How are they feeling? And I can tell you, having tried the VR, we're piloting it right now. We've heard employees say you could just feel the person gawking at them, or you could feel them in the virtual reality space. So I'm really excited about using this. I think it's going to help. Our first use of it is with the employee. I think, sometime down the road, we may try the veteran experience, but, I want to make sure that our facilities are safe, and if VR is one more way that we can help a person experience that and then look at ways to make our facilities safer, I want to do it.
No, completely agree. And I think immersive technology has such a unique capability to really enable that empathetic response to another individual's experience, and I think using it for something like the prevention of sexual harassment has a lot of potential, not just within the VA, but in general, across all of
100%.
healthcare, or just across all of society, potentially, depending on the environment it's built into. I'm curious, too, just as kind of a side conversation, as a female veteran yourself, what does it do for you to be involved in a project like this within the VA?
It is amazing. It feels like I'm continuing to serve in the VA. It feels like I can relate. I've had experiences on active duty that I can completely relate to other veterans. And I feel like I'm connecting to other women veterans. And I will tell you, harassment does not only happen to women, it happens to men as well, but we're talking about women veterans. So I just feel like I'm more connected to the mission, being a veteran myself.
Yeah, completely understand it. Thank you for that sentiment, too. All right, back to you, Dr. Siv. So, we've talked about some of the unique challenges and characteristics of our female veteran population. And how do you think, already in your work, how is this technology able to kind of better address some of those challenges?
Yeah. Well, on a clinical side, I feel very capable to evaluate, validate, and treat a woman's pelvic floor symptoms. That's something that's, my wheelhouse. However, you can imagine that every time that I'm evaluating, this requires a pelvic exam, which can be incredibly anxiety-producing, and often an office procedure, sometimes up to every 6 months. And so this has led for me to see a lot of no-shows, cancellations, or worse, people traveling hours to your office just to cancel the procedure, or leave, right before starting the procedure, related to the anxiety that they're feeling with regards to even just discussing a consent for the procedure. And worse, the risk of sedation, needing to go to the operating room to undergo sedation up to every 6 months, for something that could potentially be handled without that risk. And so I think offering an additional technology to these women to be able to stay out of the operating room, to be able to avoid sedation, to be able to more comfortably undergo an evaluation that's critical to them is something that I'm really excited to provide. And we've been working with that initially first on in-office procedures. So what I've used is a headset experience during a cystoscopy, camera look into the bladder, or invasive procedures, Botox injections to the bladder for overactive bladder symptoms or treatment of urinary leakage. And so these are invasive procedures that are now being able to be done under a much more comfortable experience. And so I just see a lot of potential. If we can do it for this, imagine everything else we could use this for.
I'm curious too, with that, especially with that particular use case, have you run into any barriers getting buy-in from the female veterans to even want to be able to try it? And if you have, how do you kind of help them overcome that hesitation?
I anticipated, and I'm so thankful to the whole immersive team, because you all helped me try to anticipate some of this ahead of time, and Dr. Rumsey too, for your advice as we're creating what experiences we want them to have. And so, we anticipated potentially noting some isolation feeling if you're going to be wearing a headset and having a pelvic procedure. I do think that's a limitation. I've not had any of the women verbalize that yet, but that's something that I anticipate being a barrier. In addition, interestingly, several of the veterans have had experiences, whether in the VA or in their personal life, with immersive technology, and so that's been exciting to see. It's so easy. I also thought when we're getting our staff on board, everybody learning how to kind of put the heads in headsets, that was going to be a difficult procedure. As you all said, the time it takes to do that, it's like seconds. It's so easy, and there's so much other downtime that it fills for the veterans while they're getting prepped, sterile drapes placed, all of this, in what could otherwise be a potentially awkward scenario while you're getting prepped and draped. You're now somewhere else, and something that you chose. And so I think that those barriers are really small for what we're seeing. Now, I will say I had a 91-year-old woman I saw 2 weeks ago, and she actually was really excited about trying, but she said, I want to do this in reality first before virtual reality. So I will say some people do want to watch the procedure and see what's happening, but age has not been a barrier for that.
I think that's a really important thing to note. I have also found that age is not a barrier when it comes to this technology. Megan, I know you have done quite a bit of work with female veterans too, so I'm wondering if you've experienced any other types of barriers to using it with that patient population, or how you've overcome those, or kind of how you talk to them about it to increase openness to this technology.
I actually haven't had a lot of female veterans say no when I've offered, and how we approach it. Thinking about this in the outpatient space, we would have them come in and demo it first, just to make sure that it feels comfortable, that there's no motion sickness, and that it feels like something they want to participate in, right? Really thinking about that informed consent. But I could count on 2 fingers the number of female veterans. I just wanted to add something to what Dr. Siff was thinking about in terms of the inpatient experience. In the outpatient experience, I think the possibility space with the use of VR really meets the moment for our female veterans in terms of what might be going on in their lives as caregivers for children, caregivers for their parents, and thinking about virtual reality as a meditation or a mindfulness component and building on what we know are evidence-based practices to help with pain, to help with anxiety, stress. And how I think about it is that having or deploying the VR, it really increases the access to that supportive behavioral technology. And then when we're working with veterans that have had MST, allowing them to take it home and use it in a real safe space where they know that when they put the headset on, nobody is coming into the room is really so important. The other thing that I would say is the female veterans that I've worked on, even though the endpoints of some of the work hasn't been about sleep, sleep ends up bubbling up to the top for their overall quality of life. And so having access to it prior to when they go to bed is really can be a sort of a game changer for how their good nights lead to good days is how I would say it. But those are things about that access that I would suggest.
And I'm kind of thinking a little bit more, which I would be remiss not to say, is it does require some anticipatory guidance and extra communication, I think. So that's something that if you're, especially on my side of things, where you're going to be performing a procedure that's very sensitive, this is something you do want to communicate significantly up front, during, and after. So while you can dissociate, you still want to be very cognizant also to continue that communication. And it's possible to do. I also thought maybe they wouldn't hear you or back and forth, but that communication is extremely important still from the clinicians to the veteran.
And one more thing I just wanted to add on to that this technology is not in and of itself the main thing. I think it's a connector. So it never replaces the clinician, because there is a feedback loop that is created with some of these experiences. And it's really important to, like Dr. Siff was saying, to have some of that anticipatory guidance and then have some follow-up as well. So it's really not about giving headsets to female veterans. It's really about that continuum of care that we want to build out, and that access to care and that choice, to also create experiences that are meaningful to the individual. Female veterans are not just homogenous. They like different things. They choose different things when given the opportunity. So it really is more complex than sometimes it starts out to be.
I think it would be helpful for our crowd here to hear more of what you've heard specifically from female veterans about their experience too. So I don't know if Dr. Rumpke, if you want to start, but I'd like to hear from all of you if you've heard anything specific. Feedback.
Of course. So there have been really some profound and experiences that I've had the privilege of sharing with some of our female veterans. In those demo experiences, what I would do is show different types of immersions that they could choose. And in one experience, I had a Korean era vet that after she chose an alpine walk, that's what she wanted to do. So I asked, can I take the headset off? And tears were streaming down her face. And I said, can you share what's going on? Where's those tears coming from? And she said, they're actually tears of joy. Because of my chronic pain, I haven't been able to go out on alpine walks, and this really felt so connecting with things that give me joy. So that is one example. I've also had women veterans, female veterans, share that they have had severe plane phobias. They don't want to fly on planes. This one female veteran told me that usually she does early boarding. She can get into her seat, get comfortable. And for this one experience, she wasn't able to get early boarding, so her anxiety was heightening. And she got in her seat, and she had been doing this breathing meditation. And so she said, I just heard the voice in my head, and I just started breathing, and I felt better. And so I think it goes back to connecting with an experience that is supportive to the veteran, and then looking at how adherence, Dr. Greenleaf talked about this, can really build those skills that help us downregulate, help us in those frightening situations. I have other stories, but I will defer to.
I would like to say one thing. Right before the pandemic, VHA, our undersecretary at the time, did these qualitative walking tours at our facilities. Almost every medical center had a qualitative walking tour for 30 days. The leadership would talk to staff and veterans and ask them about their experience about harassment or sexual assault at their facilities. And they asked, one of the things that we heard as a theme was saying that someone was attractive, or you are too pretty to be a veteran, or you are really sexy. They really thought those were compliments. They did not realize what they were saying might be offensive to a female veteran, or really to a female professional, because, I'm sure these doctors want to be called doctor, not, hot bodies or something, right? It was offensive to them, but they really did not know. It was just about letting them know that language was not appropriate. And so as you talked about the experience of these veterans, I thought about, as we do the VR training, as we introduce it to veterans, we'll have to make sure that we're not triggering anything for someone. But also, we want people to have that. We want people who have never experienced it to understand what people might experience. And so putting the headsets on the right people will also be very important to us.
No, I think that makes a lot of sense. And talking about especially the prevention of sexual harassment training in particular, I think it's applicable to, our staff, but also, as you said earlier, potentially for the veterans themselves, because sometimes people are not aware of the reaction they're causing by something they think is kind of mundane or even positive, but it is not being taken that way.
Correct, that's right.
So just increasing empathy overall. Myself as a former bedside nurse, have I experienced sexual harassment at the bedside? Absolutely. It has definitely happened. And I think that there's something to learn from that too, because if you're a nurse at the bedside, sometimes you don't want to speak up because somehow it feels negative against your patient if you're speaking out against them. You know what I mean? So I think there's
It's true, but it's finding the right words to establish a healthy boundary between the patient and the provider or a clinician, because sometimes they really don't know. And it's also just letting people know so that the proper interventions can be put into place, because we want our healthcare to be safe for veterans, but also for our clinicians. We just heard about the burnout. We just heard about hiring clinicians. We want VA to be the place of choice for employment. So we want to make sure that our facilities, our bedside, every place in our facilities are safe.
Yeah. No, completely agree. So hopefully we can move in that direction.
Yeah,
Dr. Siff, you want to add something to that from before?
Oh, sure. I agree with you. I just think the stories and the comments from the veterans are so poignant. And just a couple stick out for me on some of the experiences that they quote. One, I can recall two very particular. One woman was a former OR nurse herself, and so very familiar with all of the goings on. And she had said, I felt that I was able to not hear what was happening. Of course, anyone who's done any healthcare or bedside procedures, there's always something wrong with the equipment. Like, you don't have this, you don't have that, you're scrambling. She said it was very nice to just not, I could hear them talking, but it was not stressing me out. There was nothing happening there. I felt very comfortable during that portion. Also said, and this was a pretty invasive procedure, very, very uncomfortable injection into the urethra, one side done. She said, I was able to really quickly forget about how uncomfortable that was, and so I didn't anticipate and stay tense for the next side to happen. So I was able to kind of go back and relax enough to have the procedure completed quickly. And so that was great feedback, that she wasn't hyper-focused then on pain for the rest of the procedure. And then my favorite was one of our patients said, commented and wanted this feedback to go up to the leadership, saying, that was the most friendly experience that I've ever had, and I wish all of my appointments were like that. And as a urogynecologist, you never get that feedback. So I would say that was really one to write home about. So.
I have to say that's not a feeling I've ever had.
And I wanted to just jump in here. So we serve veterans, but our veterans have families, and part of the experience of having the headset at home were comments that the female veterans made about how their families maybe witnessed them in the headset with their bodies relaxing and feeling peaceful, and how profound that was to their families who know how they suffer. And then one more quick story about sleep. One of the opportunities that I had was convening a group of women veterans, female veterans, where we did the debriefs as a group. So they would use the VR individually at home, and again, they could choose whatever experience they want. And then we would meet weekly for 6 weeks to talk about the experiences. And one of the veterans in the group basically, with PTSD, had not slept more than an hour or 2 hours, or max 3 hours in many, many years, had tried all kinds of medications, and really nothing worked. And found that with the VR, using it before bed, was able to get an incredible 10 hours of sleep. And so she was sharing this with this group, and they knew each other pretty well. And she said, I had this appointment at the VA, so I had this great night's sleep, and I came into the facility, and one of the other members had seen her that day, and she was just remarking that I felt really good. And the other member said, your mood, I've never seen you look so good, look so like in a good mood. And when she went to see her physician that day, the physician was overwhelmed. And this goes back to, I think, healthcare as a team sport, when we're all kind of delivering what we can and what we have the access to, and then sharing that broadly with the entire community to show that we're really looking at the whole health system of care. We're looking at complementary and integrative health practices. We're thinking about what matters to the female veteran, where they suffer the most, and maybe what works. And then I would love to do more work in that group setting, because I think that's such a powerful, powerful construct about how veterans share information. As a nurse, I could suggest things, but it is so powerful coming from veteran to veteran. And so I think that might be a very interesting opportunity to explore.
I agree.
Thank you.
So my next question is going to be for all three of you as well, because I'm kind of interested in how your responses may be the same or different related to this. So I want you to think about what are the potential benefits and or limitations to this type of technology and providing female-specific care, and kind of what you hope for the future. Like, what in a perfect world would you like to see this technology helping with? So I don't know who'd like to start. Leela, would you like to start?
I'll start. First of all, I wonder if I could get 400,000 sets of headsets. How difficult would that be?
Well, I don't think Ann and I ever say no to anything, so we might be able to make it happen.
Okay, because I think that'll be important. I mean, I just think that it takes, from at least from my arm, where I'm at a strategic office at headquarters, but I'm thinking about all of the VA employees. I'm thinking about the 9 million veterans that we serve. I know that not all of them will want to take this training, but I would love to see our employees have the opportunity to take this training instead of the traditional, page turner, TMS modules, if they'd like to. It really does help with empathy. It really does help with just having that experience. It's a new way of learning the material. And I think it'll stick with them. We actually have received feedback from employees on how to make our training better. And so for me, I think it would be great to have multiple options of the training, not the routine, mundane training. I took, I love our mandatory trainings because I helped develop some of it for VA. But I would love to see different modules on the same topic or different topics in this space to keep it interesting for employees. And I think we'll have more, I think it'll stick more. Because if you're just taking that mundane training, you're pushing the next slide. Not saying that everybody does that, but you're competing with taking care of patients, doing their regular, you don't have a lot of time. So that's one thing. But keeping it fresh for employees, keeping it fresh for veterans, but making sure it meets them where they are.
No, completely agree. And to add on to that too, I'm curious what you think. So we were talking with some folks recently about how this technology could potentially be utilized as well for our veterans who may be seeking out like gender reassignment surgery to allow the clinicians, even the surgeons that are going to be performing those surgeries, kind of what it feels like to be that patient, as well as training on how to best communicate with them so that they don't have any kind of hidden bias, in the way that they speak to them too. So with your experience with the sexual harassment prevention training, what are your thoughts on using this technology for a use case like that?
I'm 100% for it.
Yeah.
I think it needs to be, it has to be developed with the right subject matter experts, but I absolutely believe we should do it. I mean, I'm completely open to it.
Yeah.
And VR will transcend those early conversations and the connection, making sure you follow the guidelines and care pathways for everything that needs to go in from your home support and your mental health support, and in addition to surgical planning. So I think that VR would be a great technology that you could interact with on a multidisciplinary way for that case in particular.
No, I completely agree. What are your thoughts too on where you'd like to see it go beyond, you're doing some great work already with procedures, with exams. I know there's been some research even showing how use of immersive technology can decrease their perception of how long they're in a procedure, which if you've had military sexual trauma, that can be incredibly impactful. But what are your thoughts? Like, what other ideas have you come up with?
A couple of things. Well, in thinking about the potential limitations first, I always think about this one patient, very exasperated. They are with with pain after a procedure, after a surgery, and was there for injections. And she said, "This was a really great experience, but I'm not going to lie, no amount of fish are going to make that feel any more comfortable." And I was like, okay, fair. So I will say there are certain limitations, right? But still had a fantastic experience for in-office procedures. For the future, I think there are a few. I mean, I think for providing a better experience for the veteran has actually been making it easier to do the procedures and to train trainees to do the procedures. The trainees are more comfortable. They're commenting that they feel more comfortable. The veterans feel comfortable having you be teaching at the same time. So I think that there's the training aspect for staff. Similarly, for staff burnout, having less, you don't need quite as many staff members in the room. If the patient is feeling comfortable, they can focus on the actual logistics of the procedure rather than anxiety reduction. So I see those as potentials. But we're working on, and I think where I see the future going is, we're asking veterans what they want to see. We're injecting the voice of the veteran into these tailored experiences. These are women who have their voices missing completely, particularly in pelvic health, but in general in healthcare within the VA. And so I think that that's where I see we're asking them what they want. We're including that. So that's another benefit. And home use. This isn't just a problem in the VA, but there is a huge lack of pelvic floor physical therapists and access to physical therapy. And I'm sure everyone in the audience can think of their particular field where there is a huge limit in staffing. But for me particularly, there is a lack of pelvic floor physical therapists, and people are driving hours. And these are, busy professional women who are taking off work to come and see you. And so we've started to work with our in-house pelvic floor physical therapists and MST coordinators to design some content that could be used in conjunction with some home activities and exercises that they could then use that to replace some of the travel trips, and that may potentially be equally as effective. So that's where I see a lot of that being tailored, being able to use it at home, and to bridge those gaps.
Yeah, no, I would agree with the home use in particular. I'm curious from your perspective too, and dealing with pelvic floor exercises and things like that. What do you think of the utility of this technology in impacting our female veterans who are pregnant, who have recently given birth, for postpartum? What are your thoughts on that?
Absolutely, and I think that's a place where we're seeing, in meeting with our pelvic floor physical therapist, I'm finding the number of pregnant women that she's seeing that I don't get to see any of because I don't do any obstetrics, and it's not done within our institution. And so I think that having that both in a VA population, in an active duty population, is where I think that you will see on the preventative side, you're going to see a lot of benefit.
Mm-hmm. And Dr. Rumsey, I don't want to forget you in this because
No,
I
it's
feel like
okay.
you've got some good ideas
Well,
over there.
I just want to echo what Layla and Dr. Sif have said, is that moving it out into the outpatient, you wanted 400,000. I'll take another 400,000. Yeah. And just to have it as a tool in the toolkit, I think female veterans need to be able to access it, try it, see if it adds benefit. And then in the limitations, I think that the limitation is closing the loop with the clinician on the other side, whether that's a telehealth clinician, whether that's an in-person, but figuring out how we do a workflow around that to chart it, to show the value of what the technology is, that it's not gamification of, that it really is active therapeutic benefit, and these are some of the outcomes that we are, looking at, and having it maybe available in prosthetics, and that it can be something that is a physician ordered, to go home with the veteran. I think that would be incredibly advantageous. One of the worst parts of my job, I often say that I have the best job in the VA, and I feel strongly about that, but one of my worst days was taking the headsets away from our female veteran. And then they would ask me, when am I going to get this back? And so I keep waiting to be able to return it to them, to the ones that want to continue to use it and find benefit. So that's my blue sky world.
Well, I'd imagine most of us in this room are excited for the time period where it is something that is just issued to them for them to use in collaboration with VA Healthcare, of course, to safely and effectively use it to benefit their care. So I know we're hoping for that. Does anyone have any last thoughts? Otherwise, we can definitely open it up to the crowd out there for some questions too.
Sure. Happy to open it up unless you all had anything.
Oh, we've got some questions. Do we have any microphones? I can give mine up.
Here we go.
Thank you so much to all of you. I really have so enjoyed this panel. I think it's been really inspiring. I'm a psychologist at the Houston VA, and my clinical interests are kind of the nexus of PTSD and couples and family work. So, but I really enjoyed so many things. So I guess I wanted to just say a few things. My head's just swirling with different ideas that you guys have brought up. But, firstly, just the importance of empathy building. And, I just think going back to some things that were talked about earlier, just like how powerful empathy is and putting ourselves in someone else's shoes. And I'm really interested in how maybe some of this could be harnessed for treating the families of veterans, and just thinking about, in particular, with couples therapy, something that I see come up for a lot of my female veterans when I'm doing, say, trauma therapy with them, is just going back to Tina's talk, the cognitive load, right, that a lot of our female veterans are carrying, not having time to be able to go to trauma treatment on their own because they're dealing with childcare and X, Y, and Z. So being able to, have spouses be able to experience, how much cognitive load is happening for veterans, and just also, on a systems level, thinking about, I was really struck by what you mentioned about, basic human rights that a lot of our female veterans didn't have when they were serving, like toileting. I'll never forget a veteran I was doing trauma treatment with, not having a bathroom they could use while on patrol, like just how traumatizing that was. And just, I know we're dealing with VA, not active military, but just if we could get these sets in the, on the heads of, patrol leaders, just to be able to experience what a day in the life of a female soldier is, just how empathy has so much power to be able to maybe change systems as well. So anyways, I'm just waxing philosophical, but thank you.
That's such an excellent point, and I'll say things that I didn't even recognize were happening. I mean, I'm so struck by the stories that women will share with you. But I can think of one where she said she would have her family members mail her Ziploc bags for her to urinate in at night because it was too life-threatening to go to the bathroom across the barracks. And so completely having that be part of staff training, I think of that from the voiding dysfunction side and the clinician side, but now that I get to interact with you all and this panel, I can 100% see how that works on the staff training side of things. Excellent point.
Absolutely.
We've got time for one more question. Okay.
Hello. Dr. Rumsey, what is your barrier to getting these headsets into the hands of veterans in their home?
Well, I think it's a systems problem.
You are free to speak.
Yes. So I mean, I think it's creating that value proposition, Liz, and it is collecting the data and bringing that data. I think Dr. Shaw, had a great point about really communicating this to our leaders and really putting it front and center. And there is a groundswell from the veterans. I think that we're getting out and allowing them to see the possibility space. And I think that that's very, very helpful to create that demand. We're pushing it from our side, right? We know it's valuable. We've seen the data. We've seen the reactions, right? And now we have this tension that I think is going to come to. We've made, I think, huge strides with this work. So next year? I don't know.
Or now.
Hopeful.
We're already getting some
Now.
devices in the homes now.
Now,
so,
now.
yes. All right, are we calling it? All right. Well, all of you, thank you so much for your time and your experience and your thoughts.